भैया हमेशा खुश रहोगे। A very good morning to you all. Myself, Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, and Faculty of Forensic Science at JAYOTI VIDYAPEETH, Jain. In the last lecture, we have discussed about rheumatoid arthritis. What is the definition of rheumatoid arthritis? What is the incidence of rheumatoid arthritis, and what is the pathophysiology? What are the different changes that are happening in case of rheumatoid arthritis? In today's lecture, we are going to continue with the clinical features. Alright? So, what is rheumatoid arthritis? Let's just do a revision, quick revision of rheumatoid arthritis. What is rheumatoid arthritis?
Arthritis and multiple.
It is a chronic inflammatory disease of unknown origin. What is the incidence? It affects
5 to 1%.
Age groups?
25 years.
25 to 55 years of age. Alright? And what are the different joints that are commonly affected? Bilaterally symmetrical. What is the pathophysiology? What are the different steps of this is an autoimmune disease involving what kind of cells?
T cells and B cells.
Very good. Alright. And the typical feature of rheumatoid arthritis is formation of okay. This leads to what are the signs of rheumatoid arthritis? There you will find
Chronic inflammation, granular formation,
destruction of
bone,
cartilage, erosion of bones, and then
synovial hyperplasia.
these are the various things that are happening in the pathophysiology case of the rheumatoid arthritis. Now we come to the clinical features. So, how to diagnose a case of rheumatoid arthritis depends on the clinical features. Right? What are the clinical features? What is the clinical presentation with which a patient is coming to us? Alright? So, let's start with rheumatoid arthritis. The clinical features. How to diagnose a case of rheumatoid arthritis, and what are the clinical features, what are the signs and symptoms with which a patient is coming to us with rheumatoid arthritis. So the diagnosis can be established by careful history and physical examination. It is similar to as we have discussed in osteoarthritis. In osteoarthritis also the history and the clinical features were very important. Alright, for the diagnosis of the disease. This is rheumatoid arthritis is basically a systemic disease. It is having affection in two planes. One is articular manifestations and other is extra. So we are going to discuss the clinical features of both in this lecture. We have articular manifestation that is related to the joint, and extra articular surface that is. So let's start with the articular manifestation. What are the articular manifestations? Articular manifestations which are related to the joint itself are the clinical hallmarks of inflammatory joint disease. The clinical hallmark of the articular disease is persistent synovitis, that is persistent inflammation of the synovial. Now, another important thing that is needed in case of rheumatoid arthritis is that the symptoms, in order to diagnose the case of rheumatoid arthritis, it is very essential that the history of this complaint should be greater than 6 weeks. So this you have to remember. If the patient is coming to you with the complaints which are less than 6 weeks, then you cannot jump directly for rheumatoid arthritis. Greater than 6 weeks. This is an important take-away message for you. If the complaints are for less than 6 weeks, then there are a lot of chances that this can be viral arthritis. Alright, so in order to make the diagnosis of rheumatoid arthritis, you have to make sure that the complaints are for more than 6 weeks in the patient who is coming to you. Alright, so 6-week cutoff is very essential to exclude viral hepatitis. If this is of recent origin, then the cause can be viral hepatitis, arthritis as well. Viral arthritis. Now, these are the changes that are seen in case of rheumatoid arthritis. This is a normal hand bone structure, the hand structure normal. And you can see the changes in the joint structure. The joints are greatly deformed in case of rheumatoid arthritis. There is displacement of the bone, the bones are getting displaced, and there is bony erosion that is seen in case of rheumatoid arthritis. So in rheumatoid arthritis, you get a lot of destructive changes in the bones and the joints of the body. Alright, so this is way more severe than osteoarthritis, and that's why we have discussed that the severity of this disease is more. There is great mortality rate, great loss of function, and great deformity of the joint. Now we are going to discuss different types of deformities of the joint that can be seen in case of rheumatoid arthritis. Now, this is again the clinical feature of rheumatoid arthritis. How the patient will come to you, how the patient will present. In osteoarthritis, the morning stiffness was for how much duration?
1 hour. More than 1 hour.
30 minutes.
30 minutes.
But I told you that in rheumatoid arthritis,
More than 1 hour.
will be greater than 1 hour. The symptoms that are occurring or which are presenting in case of rheumatoid arthritis are due to the involvement of the inflammation of joints, tendons and bursa. All the structure that are present in the joint, there is great degree of inflammation that is present in the case of rheumatoid arthritis. There is early morning stiffness lasting for more than 1 hour. If it is less than 30 minutes, then we can think of osteoarthritis. And in case of rheumatoid arthritis, in a younger age individual, the morning stiffness for greater than 1 hour that eases with the physical activity. So as and when the patient does the physical activity, the stiffness is eased. Now, what kind of joint involvement is seen in case of rheumatoid arthritis? In case of rheumatoid arthritis, smaller joints are involved and bilaterally symmetrical joints are usually involved. Initially, small joints of the hand, feet and wrist are involved. So in the hands, feet and wrists, your smaller joints are involved initially. What is the medicine for smaller joint involvement?
Actia spica.
Very good. Actia spica. And other medicine? Any other medicine? This is a specific medicine. Have you heard about chlorophyllan? Chlorophyllan. Alright. You know what is actia spica? This is sufficient. Always remember this medicine in case of large joint involvement is also seen in case of rheumatoid arthritis, and the symptoms may also occur. Symmetrical distribution, this is very important. In case of osteoarthritis, the involvement of single joint on one side of the body was more important, and later on the other joints were involved. But in case of rheumatoid arthritis, symmetrical involvement on both the sides of the joints were there. We have discussed three terms: mono, oligo, polyarthritis. Alright. So mono was pertaining to how many joints?
1.
Oligo to?
More than 2 or 4. More than 4.
So similar applies here as well. The pattern is monoarticular, oligoarticular, and joints are polyarticular, greater than 5 joints. Up to 4 it is oligo. Now, what is the criteria for diagnosis of rheumatoid arthritis? Whenever a patient is coming to you, what is the minimum criteria or what is the criteria on the basis of which you can diagnose the case of rheumatoid arthritis? So, these things have to be present in Anila. These things have to be present in order to diagnose the case of rheumatoid arthritis. Morning stiffness greater than 1 hour.
1 hour.
Right, this is very important. Arthritis of
3 or more joints.
3 or more joints. Alright, so this is very important. Morning stiffness greater than 1 hour. Involvement of
3 or 4.
Rheumatoid factor present. This is very important again. Rheumatoid factor was due to no, this was autoimmune, yes. But what were the cells that were producing the rheumatoid? Which cells? T cells. And then you forgot the last leg. Yes, sir. Radiological changes or the X-ray changes that we have just seen in the previous slides. Duration, arthritis of the hand joint. Usually the hands and feet joints are usually involved. The duration for greater than 6 weeks. This is very important. In case of less than 6 weeks, what are the chances? Viral arthritis. Symmetrical arthritis is very important, and rheumatoid nodules. You remember the rheumatoid nodules? In the last lecture, we had discussed about rheumatoid nodules, which consist of middle fibrinoid part, which is surrounded by just forgot the last one. So we have these features. Just repeat these features once again. Morning stiffness for arthritis involving rheumatoid factor. Next, arthritis of hand joint. Duration, symmetrical arthritis and
Rheumatoid nodules.
that should be present for diagnosis of the case of rheumatoid arthritis. Now, what are the articular manifestations? First of all, we are going to discuss about articular manifestation. Then we will go to the extra-articular manifestation. Sometimes rheumatoid arthritis has very acute onset. Sometimes the symptoms are coming very acutely at a very rapid pace, with morning stiffness, polyarthritis, and pitting edema. Sometimes pitting edema is also present in the patient. Once the disease process of RH is established, the wrist, the smaller joints will be involved. The wrist joints, metacarpophalangeal joints, and proximal metaphalangeal joints that are involved, that are most frequently involved. Alright? Bilaterally symmetrical, both sides of the joints are involved, and the age group will be 25 commonly. The joints are tender and swollen because of the presence of inflammation. They test positive for serum rheumatoid factor, that is important, and anti-CCP antibodies. What is anti-CCP? Cyclic protein. So anti-CCP antibodies and RF factor are positive in case of rheumatoid arthritis. They have the highest scores for physical disability. So more the scores for RF factor, more the score for anti-CCP antibody, more is the disability scale. That is, the patient is more disabled and not able to perform any of their activities. Alright, so is this clear?
Yes,
sir. Other joints are actively inflamed if they are tender on pressure. Tender is painful on pressure, alright, and have the stress pain on passive movements, or effusion or the soft tissue swelling. So there is swelling in the joint, there is tenderness present, alright. Then this is another important thing that we are going to find in the patient. This is basically flat foot. What is flat foot? Flat foot is calcaneum valgus, that is eversion reflecting damage to the ankle and subtalar joint. So there is damage in the ankle and the subtalar joint that is often associated with loss of longitudinal arm. You all must have studied the arches of foot.
Yes.
So in foot there is arches, but due to rheumatoid arthritis, and in rheumatoid arthritis there is damage to the ankle and subtalar joint. These arches are lost, leading to the development of flat foot. What is flat foot? If the patient puts feet on the floor, then whole of this feet touches the ground, and there are no arches present. Okay? So this is a typical presentation of rheumatoid arthritis. This is basically the flat foot. You can see the arches. This is the normal condition, and in flat foot you don't get arches. Alright? Is this thing clear to you? Arches of the foot?
Yes, sir.
Now we come to the deformities. This is yet another important topic of rheumatoid arthritis. What are the different type of deformities? If you don't understand this at once, don't worry. Go through this once again, and then the things will get clear to you. I don't believe, or I don't consider that you can understand all these things in just a single reading. But if you go through these deformities again and again, in 2 to 3 times you are going to understand this thing completely. So, why these deformities are occurring in the joints? The deformities are due to the progressive destruction of the joints, tendons, the capsule, and the soft tissue, which leads to the development of deformities in case of rheumatoid arthritis. deformities are very common in case of rheumatoid arthritis, which was not seen that commonly in osteoarthritis. But since this disease is appearing at a very younger age and the course of disease is more prolonged, hence you are seeing a lot of deformities in case of rheumatoid arthritis. First one is the flexor tendon tenosynovitis. Flexor tendon tenosynovitis will give you trigger finger. Have you pressed the trigger of a gun any time in your life? The trigger of your gun? Yes, in any gun. So how do you put your finger in that trigger? This way? Alright, this is not swan neck, but this is a flexor tendon tenosynovitis, which will give the appearance of trigger finger. Let me show you first. This is the trigger finger. Alright? So this is flexor tendon tenosynovitis. Flexor means flexion. Tendon, and tenosynovitis means tendon synovitis. So this will give you this type of appearance, that is known as the trigger finger appearance. Trigger finger is caused by tenosynovitis of the finger and flexor tendon. So the patient who is having rheumatoid arthritis, his one finger will remain in this position. This will be the deformity, and that is known as the flexor tendon tenosynovitis and also known as the trigger finger. The finger cannot be extended like this, but it will always remain like this only. So therefore it is called the deformity. Why this is happening? Because there is fusion of the joint. The bones get fused together and the fingers remain like this always. Alright, so therefore it is said that you will see a lot of severity in case of rheumatoid arthritis. This is more severe disease in comparison to the osteoarthritis. The middle knuckle is stuck in a bent position, making the finger look as if it is pulling the trigger of the gun. Now we will come back to this. This is the frequent hallmark of rheumatoid arthritis and lead to the decreased range of motion. So all these deformities are ultimately leading to the decreased range of motion of the joint that is involved in case of rheumatoid arthritis. Whatever joint is involved, there will be reduced function of that particular joint. Ulnar deviation. Ulnar deviation is very common. You can see this. This is the ulnar deviation. The hand is getting deviated on the ulnar aspect. Alright. So this is ulnar deviation. That is also seen. It results from the subluxation of the metacarpophalangeal joint with subluxation of the proximal phalanx. So there is subluxation of the metacarpophalangeal joint and proximal phalanx on the volar aspect of the hand. Now we come to the swan neck rigidity. What happens in swan neck rigidity? There will be hyperextension of the proximal interphalangeal joint. Hyperextension means this is the proximal interphalangeal joint. This will be hyperextended, means extension, and flexion of the distal interphalangeal joint. So you can do this thing like a swan. Hyperextension at proximal and flexion at the distal interphalangeal joint. How like this? So this is the swan neck. Hyperflexion at the proximal joint and flexion at the distal interphalangeal joint. This will give, yes. So it is easy and interesting to do it like that, but imagine a patient who is having the fingers like this only. The patient cannot turn the fingers because there is hyperextension at the proximal interphalangeal joint and flexion at the distal interphalangeal joint. That is known as swan-like deformity. This is the swan-like deformity. The patient is coming to you, hyperextension of the proximal and the flexion of the distal interphalangeal joint. The patient cannot hold anything. This is the trigger finger that you can see. Now we are going. This is the deviation, ulnar deviation of the hand. You can see the ulnar deviation of the fingers. All right, and we are also going to discuss other deformities in the next slide. We have both artery deformity. What is both artery deformity? There is flexion of the proximal interphalangeal joint and with the hyperextension of the distal interphalangeal joint. So there is flexion at the proximal and hyperextension at the distal interphalangeal joint. Exactly opposite to the swan neck deformity. This is swan neck and this is the both artery deformity. Just remember the names of these deformities. Then we have Z-line deformity that is seen in case of the thumb. What happens in Z-line deformity? We have subluxation of the first metacarpophalangeal joints. First metacarpophalangeal is the thumb joint. So there is subluxation of the first metacarpophalangeal joint with hyperextension of the first interphalangeal joint. Let me show you this deformity first. This is the Z deformity of the thumb. Now again, we will go to that discussion. What is Z deformity? Have you seen this picture?
Yes.
Now we come back to the Z deformity. There is subluxation of the first metacarpophalangeal joint with hyperextension of first interphalangeal joint. So we don't have two interphalangeals in thumb. There is hyperextension of the first interphalangeal joint. This is the hyperextension. Alright, this is Z deformity. That will give you the shape of a Z. There is subluxation and hyperextension. Subluxation of first metacarpophalangeal joint with hyperextension of first interphalangeal joint, that will give the structure like a Z. Therefore, it is known as a Z deformity. Now we have a piano key movement. Have anybody played piano? So, what happens in a piano? There is inflammation about the ulnar styloid. Where is the ulnar styloid process? So, there is inflammation at this particular point and tenosynovitis of the extensor carpi ulnaris causes subluxation of the distal ulna. So, ultimately, what is happening is that there is subluxation of the distal ulna. And because of this involvement, the styloid process is involved in piano playing. If you are playing piano, then many times this styloid process is involved and this portion is involved. Therefore, it is known as piano key movement. The hand moves like a piano. It will come later on. And the last one is the flat foot. That I have already discussed with you, that the arches of the foot are lost in case of rheumatoid arthritis. So, this is pes flavum valgus due to the chronic inflammation of the ankle and mid-tarsal region, that is leading to the flat foot. The arches of the foot are lost and this leads to the development of flat foot. So, what are the deformities that we have studied just now? First one is very good. Flexor tendon tenosynovitis. The second one is
ulnar deviation.
swan neck. We have ulnar deviation that is seen in case of the hand. The third,
Swan neck deformity.
Swan neck deformity. We have what? Hyper extension of the first proximal interphalangeal joint and flexion of the distal. Next we have
Botanier.
what is seen in botanier deformity?
Flexion of leg.
And hyperextension of distal. Next we have
Z-line.
what is seen in Z-line deformity? There is
First and joint with hyperextension.
first
Hyperextension
hyperextension of the
first interphalangeal joint.
so that gives the shape of the Z. Next we have
Piano key movement.
What is seen in piano key movement? There is
Ulnar styloid process and inflammation.
information about the
Flat
ulnar
foot.
styloid and tenosynovitis. Okay. Then flat foot. What is there in flat foot? Arches of the foot are involved. So these are the different deformities that are seen in case of rheumatoid arthritis. In osteoarthritis, we have studied about two types of nodes, whereas in rheumatoid arthritis, we have seen different types of
Deformities.
Okay. Are these deformities clear to you?
Yes.
Now, deformities. Characteristic deformities develop in the foot with long-standing cases. As the cases are of long-standing, characteristic deformities in the foot are developing. This is another important deformity. We have discussed the deformities of the hand. Now we come to feet. This is the only single one deformity that is seen in case of foot. Have you seen a cock, murga?
Yes.
This is the deformity of foot. Cock deformity. Can you see this animation? This is basically a cock foot. Cock of toe. Characteristic deformity developed in the foot with long-standing diseases. If the disease is of long-standing, characteristic deformity in the foot is developed, and in the foot, dorsal subluxation. So there is dorsal subluxation. Yes. These are basically hammer toes. All these deformities belong to rheumatoid arthritis. Alright. So there is dorsal subluxation of the metatarsophalangeal joint may result in cock-up toe deformity. So like a cock's head, this deformity represents, therefore it is known as cock-up deformity, and this comes along with a flat toe. So flat calcaneo valgus eversion reflecting the damage to the ankle and superior. This is the revision of the previous thing that is leading to the development of flat toe in individual. So we have discussed the deformities of the hand, we have discussed the deformities of the foot. This is flat foot. Alright. You can easily recognize the flat foot. Now, extra-articular manifestations. We have discussed about the articular manifestations. Now we come to the extra-articular manifestations. What are the common extra-articular manifestations that are seen in patients when individuals suffering from the rheumatoid arthritis? Extra-articular means other than joints. Other than joints, what are the different organs, different part of the body that are involved in case of rheumatoid arthritis? Extra-articular manifestation may develop during the clinical course of rheumatoid arthritis. During the development of rheumatoid arthritis, there are a lot of features, extra-articular manifestations that are seen in individuals, even prior to the onset of arthritis. So even before development of arthritis, these changes can be seen in the body of the patient who is suffering from rheumatoid arthritis. Alright, history of smoking is very important. Alright, so this you should always know. Patients have history of early onset of significant physical disability. In the patient, there is early onset disability. This we have studied in the previous lecture, that in case of rheumatoid arthritis, there is very early onset disability of the patient because of the joint involvement. Significant physical disability, and they test positive for rheumatoid arthritis. Alright, RF factor is positive. What are the common manifestations of the disease? The common manifestations include subcutaneous nodules. There are nodules which are present subcutaneously in the body. Secondly, Sjogren's syndrome, pulmonary nodules, and anemia. These are the common symptoms of extra-articular manifestations in case of rheumatoid arthritis. Alright, so we have subcutaneous nodules, secondly Sjogren's syndrome, pulmonary nodules, and anemia. There is reduced incidence of Flaherty syndrome and vasculitis. These are all related to the extra-articular manifestations of rheumatoid arthritis. Alright, let me discuss them one by one. So this is the picture showing various extra-articular manifestations. Rheumatoid arthritis is not only involving the joints but other important organs of the body, like it is causing neurological changes in the body, it is affecting hematological system, it is also affecting GI system, skeletal system, skin, endocrinal system, cardiac system, pulmonary system, oral and ocular changes. So it is affecting, the rheumatoid arthritis is affecting lot of systems other than the joints. So it is also having lot of extra-articular manifestations. Let's discuss them one by one. Now, what are the constitutional symptoms of extra-articular manifestations? Alright, so what are the constitutional symptoms?
Weight loss.
Constitutional symptoms are basically those symptoms which are present in the disease and which do not present to any specific disease. Alright, so constitutional symptoms which are present with rheumatoid arthritis includes weight loss, fever, fatigue, malaise, depression. So any patient who is having joint pains, alright, and with the joint pains, the patient is having extra-articular manifestations that includes subcutaneous nodules, anemias, and other system involvement. The patient will be having fatigue, there will be great fever, weight loss, malaise, and depression. Depression is very common in these kind of patients because of their disease condition. The nodules. What kind of nodules are present? We have subcutaneous nodules which are firm, non-tender. These are not painful. The nodules which are present in the body of rheumatoid arthritis patient are non-tender. Means they are not painful on pressure. And these are adherent to the periosteum, tendons, or bursae due to the repeated trauma. Due to the repeated trauma, these are formed, or irritation on forearm sacral prominence. So you will find lot of subcutaneous nodules. I have shown you the picture of subcutaneous nodules in the last lecture. Alright. Then Sjogren's syndrome. the Sjogren's syndrome consists of presence of keratoconjunctivitis sicca, that is dry eyes. We have xerostonia. The patient has dry eyes and dry mouth. In association with another connective tissue disease, it occurs in 10% of the patient with rheumatoid arthritis. So Sjogren's syndrome consists of keratoconjunctivitis sicca, that is dry eye and dry mouth. So the eyes and the mouth of the patient become dry. And let's complete this extra manifestation, and then we are going to finish this class. Alright? Just go through these extra manifestations once. It occurs in 10% of the patient with rheumatoid arthritis. Next, we have pulmonary manifestations. Pulmonary manifestations are related to the lungs. Most common pulmonary manifestation is pleuritis. Pleuritis is inflammation of pleural cavity. It presents with pleuritic chest pain. Whenever there is inflammation, you will have pain. Alright? So pain in the pleuritic chest pain and dyspnea, as well as friction, pleural friction rub with effusion. Alright, so these are the symptoms, extra-articular manifestations that you can see in cases of rheumatoid arthritis. Interstitial lung disease. This is an important disease that you should know in the respiratory system. What is interstitial lung disease? Alright, so you have to go through this disease. Many times you get short note on interstitial lung disease. Alright, so this may result from rheumatoid arthritis and may occur with the symptoms of dry cough. So interstitial lung disease can present with the symptoms of dry cough and progressive shortness of the breath. Pulmonary nodules may be solitary or multiple. We can also have cardiac manifestations of the heart, which includes pericarditis that occurs in 10% of the patient, cardiomyopathy, and another clinically important manifestation. Mitral regurgitation is the most common valvular abnormality that occurs in RA. This is very important. In patients of RA, cardiac abnormalities are very common, and especially mitral regurgitation is very commonly seen. So this you have to keep in mind. Whenever a patient of RA is coming, rheumatoid arthritis is coming to you, you will many times find cardiovascular changes, and especially mitral regurgitation in such cases. Long-term cases can affect the cardiovascular system. Next, we have vasculitis. Vasculitis consists of the rheumatoid vasculitis, typically occurs in patients with long-standing diseases. Because these diseases are occurring very early in your life, hence a lot of changes are seen as the disease progresses. A positive test for serum RL, this you have to write always, rheumatoid factor positive, and hypocomplementarial. The cutaneous signs that we will find in case of vasculitis includes petechial hemorrhages are seen, small bleeding surfaces are seen, purpura is there, digital infarcts. You will find infarcts in the digits. As the disease progresses, you can find gangrene, and in severe cases, painful lower extremity, ulcerations are found. There are other meteorological features will include normochromic normocytic anemia, because anemia was one of the features. Extra-articular manifestation. This often develops in patients with rheumatoid arthritis. Degree of anemia parallels the degree of inflammation. More the inflammation, more the anemia. Alright, and as the treatment progresses, the inflammation is reduced and the quality of anemia also reduces. Correlating with the level of CRP, C-reactive protein, this I have already told you, and ESR. So ESR and CRP represent inflammation. The more the value of CSR and ESR, CRP and ESR, the more is the inflammation, and more is anemia, more is the severity of the disease. And as the value reduces, that means the inflammation has reduced and the general quality of the patient will improve. The disease will regress. Next is Fratty syndrome. Fratty syndrome is basically a triad of neutropenia, splenomegaly, rheumatoid arthritis is seen in less than 1% of the patients. So I will do the lecture till now only, and in the next lecture we are going to continue with the extra-articular manifestation. Alright, this is more than enough for you today. So we will continue the lecture tomorrow. Alright. So this session was powered by digital version 2.0, JAYOTI VIDYAPEETH University. I hope you are satisfied with the digital session. If you have any query, please mention in the comment box and I'll try to answer. So this was all for today. Thank you very much.